topic is going to be on dementia symptoms that may be reversible. So before I delve in, we're going to discuss our learning objectives for today. So we're going to discuss and define age-related memory loss versus other forms of dementias. We're going to identify reversible symptoms of memory loss. And then we're also going to discuss some local resources that are available. So 10 warning signs. So these warning signs do not go in any particular order. You can obtain a sheet, a checkoff sheet on the Alzheimer's Association website, which is really resourceful, and it goes over all of these warning signs. So at the end of this section, I'll explain why that's important, why early detection really does matter. So memory loss that disrupts daily life. For those of you here in Reno, what do you think that means? Memory loss that disrupts daily life. Yes.
You forgot where you parked your car.
Maybe perhaps forgetting where you parked your car, right? Maybe misplacing your keys somewhere, and then, retracing your steps. So typically, memory loss that disrupts daily life is forgetting recently learned information. Typically, persons who are showing signs and symptoms of a form or type of dementia, you tend to see them asking those questions, more regularly. It might be, you visit with them, they tell you the same story over and over again. So the more that they tell you the same story, the more that they ask you the same questions, that could be a warning sign. And the reason for that is, what is the first area of the brain to deteriorate with this disease process? Your hippocampus. And our hippocampus houses our memories. Right, so that recently learned information is a warning sign. What's typical age-related changes is sometimes forgetting names or appointments, but remembering it later. We all do that, right? I bet you everyone here who's logged in and who's present has forgotten an appointment one day or another. So it happens. That's normal and typical aging. It could be related to stress as well. So another warning sign is challenges in planning or solving problems. So for this section, I'm just going to refer to Reno. So what do you think that means? Challenges in planning or solving problems. Maybe it's difficult for them to develop or follow a plan. Maybe it's becoming more difficult for them to balance a checkbook if they still do that. So that is definitely a warning sign when dealing with persons who are showing the signs and symptoms of this disease. Other things that you can be mindful of is maybe perhaps checking in drawers in their offices, in the kitchen. What they'll tend to do is they'll put their bills in drawers and not address them because it's become too much for them to understand how to manage, how to pay a bill. Because if you think about the steps in paying a bill, if you're still writing checks, there's a process to it, correct? Even writing out a check becomes hard and cumbersome. So these individuals start to hide bills in places because they no longer know how to pay for those. So some typical age-related changes, making occasional errors when balancing a checkbook. On the Alzheimer's Association website, there are videos of real-life stories of persons who are diagnosed early on and some of the issues that they encountered when going through the process and progression of the disease. And there was a lady in her 50s who's had early onset Alzheimer's, and her problem was she could balance her checkbook just fine on a piece of paper, just perfectly. But if you put coins in front of her, she did not know that a quarter was 25 cents. She did not know that a dime was 10 cents. She couldn't add that up and calculate it. So it affects different areas of the brain for each individual. So difficulty completing familiar tasks at home, at work, or at leisure. This is just what it means. You're finding it it's a lot harder for you to do those activities of daily living. You find it a lot harder when you go into work to get started with a project. There was a gentleman too who would come into work and it would take him literally 2 hours to kind of review all of his notes that he left on his desk before he could really understand, what's the next step? I don't know what to do here. So he was showing those signs and symptoms. Versus typical age-related changes, occasionally needing help to use the settings on a microwave or to record a television show, right? That happens. We see that a lot with how technology has advanced, and even I have difficulty managing the remotes on my television. So we're all aging. It doesn't matter what age group we are in. So it happens to all of us. Another warning sign is confusion with time or place. So what do you think this means here in Reno? If you're not retired, which it tends to happen, or not on vacation mode, you kind of forget what day or date it is because you really don't care, right? You're on vacation. You're just in that sort of fog brain. You don't want to know what day it is. You want to enjoy your time off. Well, persons with this disease, they'll forget what year it is. They'll forget what president, we have in office, so on and so forth. Versus typical age-related changes is getting confused about the day of the week, but figuring it out later. Another warning sign is trouble understanding visual and spatial relationships. What do you think here in Reno that means? What tends to happen with the brain cell death within the brain and the neurons is that areas operating in the occipital lobe start to deteriorate. So individuals who have a form or type of dementia have vision problems. This is why typically the first questions that we ask is, well, are you still driving? How far along are you in the disease process? So you can help kind of gauge. Oftentimes I've asked caregivers, if they're long distance caregivers too, if they're here visiting, to go outside and check their loved one's car or the person they're caring for's car. If there's a lot of dings and dents, that could be a warning sign. I had one individual share with me that it was difficult for her to remove the license of her spouse because he was the main person to transport them from point A to point B. She couldn't drive and she relied on him, but he was showing the signs and symptoms. So what do you do in those circumstances? How do you help, with that? And sometimes too, trying to give up their license. I mean, if somebody came up to you and said, I'm taking your ID, I'm taking your license, you can no longer drive, how would you feel? A loss of independence, losing your autonomy, or you just act out. No, it's not going to happen, and I'm going to figure out a way. I had one client whose spouse, that had to happen. She had to remove, hide the keys, hide, his license, like he couldn't drive anymore. Well, he was very savvy. Even though he was progressing in the disease process, he was able to hotwire the car. I'm not even kidding. So he was no matter what she tried to do, he was still able. And it was like, so it varies with each individual. He was able to find the keys that he hid and made duplicates of. It was very interesting. So you just have to be mindful on how you can address those situations. Oftentimes the DMV will work with you. They can send a letter. You can ask the doctor to be the bad guy and relay the news so the caregiver isn't the one who's, labeled the bad guy with regards to that. Other things too to keep in mind with this visual decline is if your home is all the same level and you have like a step up or a step down, they may likely increase their risks of falls because they can no longer gauge that. They can't see that it's a step up or step down, especially if it's all wood flooring or all carpeting. So caregivers have been very clever in their way and techniques of avoiding those areas, either putting up a baby gate. Some put black mats in front of those areas. And the reason for that is as the disease progresses, the individual sees that black mat as a whole, so they'll avoid going to those areas in the home. Whereas typical age-related changes is vision changes related to cataracts as we age. And if we have surgery, can be removed. Another warning sign is new problems with words and speaking or writing. So oftentimes persons who are showing these signs and symptoms, they have more or less brain farts. We all have that, where we forget a word and we're trying to describe the word that we're trying to say or relay. But individuals who are showing these signs, they'll first call this a watch, then it becomes a clock, then it becomes any word, and then it becomes not even words, just letters put together of what they're trying to describe. Oftentimes too, what will tend to happen is you will be conversing with them, and midway through a conversation, they'll stop speaking. And no matter what you try to do to engage them or help them recall what they were talking about, the thought is lost. They can't retrieve it. So that's what tends to happen with individuals who are showing these signs and symptoms. Whereas typical age-related changes are sometimes having trouble finding the right word. Another warning sign, misplacing things and losing the ability to retrace steps. I'm pretty sure all of us here in the room has misplaced things. We just mentioned it, keys, glasses, a thought, right? You come into the room and you're excited to share some information with somebody and you forgot what you were going to say, right? So then what do? We just say, well, if you're lazy about it, well, it wasn't that important. I'll think about it later. And that mentality, just thinking about it later, that's very different from a person who has this disease. What tends to happen is that thought is just lost. So they'll forget where they put the keys. They'll forget where they put their purse, which is why those who are closest to them, they accuse of stealing things because they've forgotten where they've put these things. I had one client who shared with me that her mother would always blame her for all of her collections that she would have, that things would start missing. And there was one day where she was there and she was cleaning the house or walking around and she saw her mom grab an item and then put it somewhere else. But again, they don't remember or can recall that they were the ones who did it. So they blame the person who's closest to them. So typical age-related changes, misplacing things from time to time and retracing our steps to find them. Decreased or poor judgment. So this usually revolves around decision-making and dealing with money. I had one client whose father, she was a long-distance caregiver, whose father was the primary caregiver for the mom who had the disease. And she noticed she had durable power of attorney. So she was just managing, checking his finances, and noticed that there was a substantial amount of money that was being taken out on a weekly basis. So she called dad and just inquired, what's going on, what's happening? Well, after further investigation, she found out that her dad was giving obscene monies to telemarketers. I mean, that typically happens with the aging process, but her dad was very savvy and very careful with the money. So this was definitely not the type of behavior she was used to. And then after, more investigation, found out that dad was showing signs and symptoms of the disease process as well. So another thing to keep in mind too with regards to this is if you're concerned about somebody or you're just interested in knowing, perhaps opening up their refrigerator or their pantry. If they're not an avid collector or a couponer, then maybe if you see like 10 cartons of milk, 5 dozen eggs in their refrigerator, just items that they're not going to be using, that's a warning sign. And why do you think that is? They forgot that they bought it. So they go to the grocery store and they're buying the same item over and over and over again. So that's a warning sign. And then typical age-related changes, making a bad decision once in a while. We learn from that. And I remember my last class, I shared that even I was concerned. I had a call and they left me a message. They left me, the chart number or whatever it was and said that I had a civil lawsuit against me. And if my social security number ended in 4567, to call back and so on and so forth. And then in some sort of county, I'm like, God, that sounded like, Nye County or something that was here in Nevada. So I'm like, what? Like I've only traveled there for my rural trainings. Did I do something wrong during my travels? So I called them back. Well, before I did, I called my brother and my dad, they're attorneys and judges. And so I'm like, this seems kind of shady. I don't recall this. I don't remember this. And they said, Dolores, it's a scam. This is what they do. But I wanted to call back and just hear what they do. How does this scam work? So I called them back and they asked me, oh, yes, I know. Yep. Dolores, so does your social end in, 4, 5, 6, 7? I'm like, no. And they said, oh, so what is your social? And then, so I gave them a bogus social just to hear the process. And then they said, okay, perfect. So we can relieve this. It's a $5,000 civil suit, but we can relieve it for $500 for you today. Do you have a credit card available to pay that off? And so that was the scam. So just being mindful of those things too, because even with older adults who don't have, these signs and symptoms can be conned into doing it because they're concerned and worried. So another warning sign, withdrawal from work or social activities. As I mentioned, you know that something's wrong. You can tell by the interactions that you have. It becomes very overwhelming. So what do you tend to do then? If you know that something's wrong, mentally, cognitively, would you like to engage in more conversations in social settings? No, you try to, be more reclusive and not engage in those types of settings. So you see them withdraw from work and social activities versus some typical age-related changes are sometimes feeling weary of work, family, and social obligations, right? So the last warning sign is withdrawal from work. Oh, that was a duplicate. Sorry, that was a duplicate on my end. The last warning sign is in changes in mood and personality. That was my typo. So the example I give with that, so changes in mood and personality. So say you're in a foreign country, you don't understand the language, you don't understand the culture, and you're trying to communicate with somebody in the sense of directions. How do I get to the nearest coffee shop? Well, you're asking this individual this question, and they respond to you, but it's not the answer you're looking for. You're like, where's the nearest coffee shop? The sky is blue. Great. So where's the nearest coffee shop? My blouse is red. And this happens over and over again. How would you feel after a while, after asking the same question over and over again? Frustrated, angry, some become silent. So there's changes in moods and personality as this disease progresses. So if you have the opportunity, you can go onto the Alzheimer's Association website. You can download this checklist, the 10 warning signs. And what's recommended is that if you know somebody who shows 3 or more of these warning signs, you want to encourage them to see their primary care physician, because it could be a reversible type of dementia that we're going to be discussing later on today. So the last piece of information I will share with you with regards to these warning signs, or if you're concerned about yourselves or somebody in your family, is if you remember that you forgot, you're in good shape. Okay? So be relieved in that. So now we're going to jump into dementia. So I'm going to pose this question to those participating in Las Vegas. So what do you think the difference is between dementia and Alzheimer's disease?
We've got one person here, hold on.
Okay, thank you.
Comment here from Kay Campbell. Dementia isn't a type term. Alzheimer's is a form of dementia.
Dementia is like the big umbrella, and Alzheimer's would be one type.
Perfect, exactly. So dementia is the umbrella term that describes a group of symptoms that affects one's cognitive functioning, and Alzheimer's disease is under that umbrella term. It's a form or type of dementia. So we're going to go over that here a little bit more and in more detail. But before I do, I want to share with you the history of dementia. So as we know, Alzheimer's disease is the most common form or type of dementia, and it accounts for up to 60 to 80% of types of dementias. It was first discovered by Dr. Alois Alzheimer's in 1906. He was a German psychiatrist and neuropathologist. So in 1901, he was working at a psychiatric hospital in Frankfurt when he met the 51-year-old woman named August Dieter, who was admitted for treatment. She was suffering from depression, paranoia, delusional thinking, hallucinations, and dementia. So this patient would become his obsession for the next 5 to 6 years. So in April of 1906, she died at age 55. Dr. Alzheimer recognized that she exhibited signs and symptoms from a disease process that he was not familiar with and had not been previously described in literature. So it was through his studies of her brain that he found the hallmark of Alzheimer's disease, which are the plaques and tangles in the brain, and then coined Alzheimer's disease. So that's where the history stemmed from, was from this client or from this patient. And because of her age, she was younger onset or early onset Alzheimer's. So we'll discuss a little bit what that entails. These are individuals who have Alzheimer's disease before the age of 65. And typically, it accounts for a small percentage, 3 to 5%, and there's a huge genetic correlation or link with that, who have younger onset Alzheimer's. And it was during his studies, too, that he met the physicians, Dr. Frederick Lewy, who coined the Lewy body dementia, as well as Arnold Pick, who coined frontotemporal dementia, also known as Pick's disease, during his studies and research. So understanding dementia. So as I mentioned, it's the umbrella term that describes a group of symptoms that affects one's cognitive functioning. So the symptoms can cause changes in their memory, in their language, in their thought and behavior and mood, similar to what we just discussed with the 10 warning signs. So it's those types of impairments that help you understand the dementia process. So dementia itself is not a diagnosis. What I typically help persons understand is think of cancer as the umbrella term. What do you typically ask somebody who has cancer? What kind or what type? So typically when somebody says that they have dementia, you follow up with, well, what kind or what type of dementia do you have? Because with each type and type of dementia that you have, there are different hallmarks of that disease, just like with different types of cancers. So we're going to go on to vascular dementia. Does anyone here in Reno know what the vascular system controls or does, or what could cause vascular dementia? Strokes, any reduced blood flow to the brain, to the heart, right? So whatever is healthy for the heart is healthy for the brain. So vascular dementia is often considered to be the second most type or form of dementia. So it's characterized by impairment caused by reduced blood flow to parts of the brain, depriving nerve cells of food and oxygen. So some of the hallmarks of this disease is that it causes decline. So it's gradual and the decline is over time. It's not as sudden as persons who are diagnosed with Alzheimer's disease. And it could include symptoms of memory loss or memory impairment, confusion, as well as difficulty with following instructions. So people who develop vascular dementia have had histories of heart attacks, strokes, high blood pressure or high cholesterol levels. Again, whatever is healthy for the heart is healthy for the brain. So whatever deprives that flow can cause your increased risk of developing vascular dementia. So Lewy body dementia. Who here is familiar with Lewy body disease or dementia in Reno? What is your would you like to share what your understanding of Lewy body dementia is, or the hallmark of that disease?
Well, I really don't know. I mean, I know somebody that had it. But it says Parkinson's disease. Parkinson's. Yeah.
So it's individuals who kind of display the same symptoms as Parkinson's.
Yeah,
very difficult to diagnose.
It is very difficult to diagnose. Most of these other forms of dementias outside of Alzheimer's disease and vascular dementia are very difficult to diagnose. So you kind of go by some of the behaviors that you see. So persons who have Lewy body dementia, there's a huge correlation with their visual hallucinations. These are individuals that you see in nursing homes or in their own homes who are talking to themselves or looking at the mirror and conversing. I've had individuals who have very vivid hallucinations to where one has a pet dog that needs to be fed and walked on a daily basis. So it varies in with regards to the Lewy bodies in the outer cortex of the brain and how that affects the person. So typically what tends to happen is the person starts with a wide variations of attention and alertness. Symptoms are often similar to those with Alzheimer's disease, but some of the symptoms that are unique to Lewy body are memory problems, poor judgment, confusion, and other symptoms that can overlap Alzheimer's disease. Another thing too is movement symptoms are also common, including stiffness, so very similar to those who have Parkinson's disease. So it kind of follows that. So what we know about Lewy body is that it affects the nervous system and it gets worse over time. So what tends to happen is that Lewy bodies at the base of the brain are closely linked to problems with movement or motor symptoms. So these are the main features of Parkinson's disease versus those on the outer cortex of the brain that really affect those visual hallucinations with persons who are diagnosed with Lewy body dementia.
That's the ones from ones I've read, like Robin Williams, for example.
Yes.
With horrible sleep disruption, which is very distressful, which ramps up depression and the hallucination, and of course body movement.
Yep.
And so it's pretty hideous work.
Yep. So the comment here in Reno was with regards to Robin Williams and with his depression and showing those signs and symptoms. It's a very difficult process to go through, and all forms, I feel, of dementia, regardless of what it is. It's a very difficult process, and I will share with you how one ends up passing away with Alzheimer's disease. So once we get to that section as well. Okay, so frontotemporal dementia, also known as Pick's disease. Here in Reno, has anybody encountered somebody who's had this diagnosis? One of you? And what is a couple of you, and what's your understanding of frontotemporal dementia?
My personal example is my sister, who has been diagnosed with FTD, which affected her verbal skills.
Okay.
But the cognition level, she knew what was going on
Right.
for the longest time.
Yep, so it affected her verbal skills before the cognition. So that leads me to the main point of with regards to what deteriorates with somebody who has FTD. So it's the frontal and temporal parts of the brain which control personality, behavior, judgment. So what tends to happen with somebody who is diagnosed with FTD is the personality and behaviors occur before the memory loss. So what tends to happen is these individuals will say off-color remarks. They've lost that social filter. Something as the example I've given is we all know that we may think of something, we might whisper it to our partner or whoever we're with at the store, and there's a person there that's just wearing a very hideous outfit, but you're just thinking it, it's in your head. You're not going to say it out loud to the person. But these individuals have lost that social filter, so they'll just verbally say what comes to mind and just scream out, "That's the ugliest outfit I've ever seen," right? So just being mindful of that. Another thing to keep in mind is that you might see these individuals have a strong urge to eat, and you see weight gain due to it. And this could be because they might have forgotten that they've eaten before. So, persons with this disease process, you have to just be mindful that the personality and behavior occurs before you see that memory loss decline.
The ability to speak is lost, totally.
And the ability to
The
speak.
verbal, what you're saying is
Mhm.
conversation. You can't talk.
Mm-hmm.
And that's the hardest thing to know. The individual had been a supervisor in a post office, and yet for a
Right.
couple of years not knowing has been reprimanded until we got together as a family and found out that she had no idea how to go back to her position to get going back to work, to get cleared. That ability is gone.
Yeah, the ability to verbalize or to speak also deteriorates. So it varies with each person. So what might affect one person affects another person differently depending on the diagnoses. And typically this occurs at a younger age. So usually people from 50 to 70 years of age. And the person that, a couple of the clients I've dealt with, there was a gentleman who was 55 years old who was diagnosed with this disease and had young children in the home. He was the breadwinner. It was very difficult for them to kind of manage his care, especially as the disease progressed, because he became more violent. He became more physical as the disease progressed. So it varies for each individual. So again, just involves changes in personality, judgment, planning, and social skills. So rare forms of dementia. So Creutzfeldt-Jacobs disease, has anybody here heard of that, CJD? So this is a progressive neurological disease that causes, so with this disease, it's more rapidly fatal. There is a genetic link with persons who have this disease process. Symptoms are similar to other types of dementias, including memory impairment, behavioral changes, and coordination. But the genetics are thought to play a role in whether or not people suffer from this type of dementia. This is a more, as I mentioned, more rare form of dementia. And once diagnosed, it usually is about a year's time of living with this disease process before the person passes with this diagnosis. So Huntington's disease is an inherited progressive disease or disorder that causes irregular movements of the arms, legs, facial muscles, personality changes and decline in the ability to think clearly are some hallmarks of this disease. And with this disease as well, there is actually a clear genetic link, and persons can live up to 15 years upon diagnosis with Huntington's disease. So Parkinson's disease is a progressive disease of the nervous system marked by tremor, muscle rigidity, and slow and precise movement. It is associated with degeneration of the basal ganglia of the brain, which is controls the involuntary movements. So, and then deficiency of neurotransmitter dopamine. So it affects control of movement, resulting in tremors, stiffness, and impaired speech. Many individuals who are diagnosed with Parkinson's will develop a form of dementia, which we kind of know by now is Lewy body dementia, as the disease progresses. So it increases the risk of developing that. So Wernicke-Korsakoff syndrome. I'm pretty sure you all know what this is. This is just a medical term for it. This is alcohol-related dementia. So these are individuals who have a deficiency of thiamine in their system, which is vitamin B1. Thiamine helps the brain cells produce energy from sugar when thiamine levels are low. Of course, the most common cause is alcoholism. So symptoms include confusion, permanent gaps in memory, and problems with learning new information. Individuals may have a tendency to confabulate or make up information they can't remember. So there may be gaps in their memory, and they fill it with the story that they truly feel happened to them, and that's their truth. So if caught early enough, this disease can be reversed, and it's just a matter of stop drinking and having more vitamin B1 in your system. But once it is so progressive, there's no way of reversing that. It just becomes a progressive disease process similar to a person who has Alzheimer's disease, where it affects their memory, behavior, coordination, so on and so forth. I had one individual whose spouse had Wernicke-Korsakoff syndrome, but she said he would have lucid moments though, where he would remember things. So we said, well, let's do an experiment. You know, does he drink clear or, you know, dark? And she's like, clear. So I'm like, okay, so more or less vodka. So I said, what you might want to do is start to dilute it with water, because maybe they can't tell the difference as you do it over time, and see how that works, to where, you know, in the end, he's just drinking water and not knowing. It's that placebo effect. So we did that for several months, you know, and seeing the changes. And for him, you saw a significant change in their memory, and it was regained. So, but everybody's different, so it happens differently for each individual. Yes.
How long did he have
That is a good question. I'm trying to remember when we asked that question. I can't recall how long he had been, you know, an alcoholic and how long that had been. So, but she was the one who came up with the diagnoses that he had, you know, he's showing memory loss because of the, you know, his intake of alcohol. And so it wasn't an actual diagnosis where she went to a neurologist or her primary care physician. So then we decided, well, let's just do this experiment and see how it works for you. Because maybe it's caught early enough and he's not consuming as much as what would cause this brain, you know, disease to occur. So luckily for her, it wasn't as severe as it could have been to where it couldn't be reversed. So what is Alzheimer's disease? So Alzheimer's disease is a progressive degenerative disease of the brain that affects memory, thinking, and behavior. It is the most common form of dementia and accounts for 50 to 70%. It is the 6th leading cause of death in the U.S. In the nation. It affects over 5 million people here in the USA, and by the year 2050, that number will triple to about 16 million. And it has no cure. So what do you think is the hugest risk factor of developing Alzheimer's disease here in Reno?
Care providers.
What was that?
Care providing.
Care providing or care providers,
Yeah.
the quality of care? Nope, what is the main cause of it? The main cause? Genetics? What is them? Alcohol? Age.
Diet.
Age is the hugest risk cause or risk factor of causing Alzheimer's disease or any form of dementia. So I'm going to give you the statistic there. Those who are 65 years and older, 1 in 9 will develop this disease. Those who are 85 years and older, 1 in 3 will develop this disease. So some statistics I wanted to read to you all. Alzheimer's disease kills more than breast cancer and prostate cancer combined. Since 2000, deaths from heart disease have decreased by 14%, whereas deaths from Alzheimer's disease have increased by 89%. In 2017, Alzheimer's and other dementias will cost the nation $259 billion. By 2050, these costs could rise as high as $1.1 trillion. So as I mentioned too, there is no cure of this disease. What tends to happen is we all know what the brain controls, right? It's like a factory, well-oiled machine. But once you see certain areas start to die off and not functioning properly, that shuts down certain organs in your body. So if that brain cell death doesn't shut down those organs and the person dies from that, the last thing to deteriorate in your brain is your brainstem with this disease process. And what does the brainstem control? Swallowing and breathing, which is why you hear a lot of cases of persons who eventually pass with this disease having aspiration pneumonia. So that's what tends to happen with the individual who's diagnosed with Alzheimer's disease. So this is just a picture to show and depict a person who's died just from normal age-related causes on the left-hand side. And on the right-hand side is somebody who has passed with a former type of dementia. So how much do you think our brain weighs? About 3 pounds, correct. So how much do you think your brain weighs after the progression of this type of disease? 1 to 2 pounds, which is why you see the severely enlarged ventricles, the shrinkage of the cerebral cortex, and the shrinkage of the hippocampus. So now we're going to discuss the reversible types of dementias. And this accounts for up to 10%, right? So most people, question and get excited, wow, you can reverse, dementia. Well, again, that's, what did I mention what dementia was? was a group of symptoms that affects one's cognitive functioning. So it's just those symptoms, right? It's not, I'm not saying I'm going to reverse your Alzheimer's disease or reverse your FTD. It's just reversible types of dementias. So we're going to discuss more in detail brain disease. What does that look like? Tumors, delirium, that acute state of confusion, depression is a disease process too. How does depression play a role with somebody who might show some cognitive loss? Eye and ear impairments, what does that mean? Infections, like urinary tract infections, pneumonia. How does that affect one's cognitive abilities, right, to function properly and to have that quality of life and doing their activities of daily living? So the metabolic or endocrine disorders, what is the thyroid control? What does that do? And then malnutrition or dehydration, undernourished, overnourished, not getting enough water. What does that look like for an older adult? And then adverse reactions to medications, which is very common as we get older. What tends to happen there? So brain disease. We're going to discuss tumors. We're going to discuss normal pressure hydrocephalus, what that means, and then subdural hematomas. So what is a tumor? A tumor is a collection or mass of abnormal cells in your brain. It can be cancerous, which is malignant, or it can be non-cancerous, which is benign. Symptoms of brain tumor depend on several factors, including the tumor's type, size, location, and extent, as well as age, health, history, and more. So some common signs of brain tumors include speech problems. Some brain tumors can cause difficulty with speech. A brain tumor can impact cognitive abilities and result in memory problems, poor concentration, confusion, difficulty thinking clearly, or processing information, and language difficulties. You might see too somebody who's diagnosed with this disease process, not so much a tumor, but it could affect them too, is persons go back to their native tongue. I had one individual she was an adult caregiver for her mother who was Russian. And the mother spoke English just fine. They had been in the country for a very long time. Well, she got diagnosed with the disease, with Alzheimer's disease, and she saw slowly but surely she no longer could speak the English language, and she went back to speaking Russian the whole time. So she had to be there 24/7 to be the translator as well. And even then, it wasn't, the language that she was used to too, because the mom was developing the disease process and it was progressing. So that can tend to happen with regards to language difficulties. There are also some subtle signs of brain cancer that may affect an individual's overall sense of well-being. The brain is responsible for many functions, so sometimes a tumor on the front part of your brain can cause gradual changes in behavior, personality, and thinking. So what tends to happen is that these affect and impact the hormones, resulting in symptoms that are very similar to those with endocrine disorders, with tumors. And so I had an individual who ended up volunteering when I worked at the Alzheimer's Association, who had a tumor. And she thought that she was showing signs and symptoms of dementia. And so she kind of pre-diagnosed herself and saying, well, I guess I just got, the short straw. And I have a former type of dementia because of my memory loss and things that have been happening. So what we had suggested for her to do was to see a neurologist or to talk to her primary care physician, because it could be a reversible type of dementia. And lo and behold, she had a tumor, and it was significant. So after all said was done, the tumor was removed, there were some areas of the brain that caused that brain cell death that she couldn't regain, but it was no longer a progressive disease. It stopped there. She could still learn new information. She could still put things into her memory bank in the hippocampus and short-term memory. There was no loss there. There were just certain stories or certain things from her childhood that, with the cause of the tumor, affected her ability to recall or to have that due to that brain cell death. So again, it mimics persons who have tumors, bottom line, mimics the same signs and symptoms as somebody who might be diagnosed with a former type of dementia. So normal pressure hydrocephalus. So NPH occurs when excessive cerebral spinal fluid accumulates in the brain's ventricles. As brain ventricles enlarge with excess cerebral spinal fluid, they can disrupt and damage nearby brain tissues, causing symptoms of NPH. So this could be bladder control, sense of confusion, inability to speak, inability to do their activities of daily living. I had a client who shared with me, she and her spouse, it was her husband's mother who came to live with them, and she was diagnosed with Alzheimer's disease, but after further testing, they found out that she had normal pressure hydrocephalus. So what they ended up doing was, the mom, before all of this happened, she was unable to hold her head up. So at the table, she kept slouching, her head was very heavy. So it would always draw closer to the table. I mean, it would hurt her back, but that's all she could do unless she would hold it up. So after further testing, what they suggested for her to do was to do a cerebral spinal tap. So what they ended up doing was they removed, just as a test, some cerebral spinal fluid, out of the brain to see what changes might occur. So as I mentioned, she couldn't really speak well. She was lethargic. She, couldn't function, didn't have her activities of daily living. Her quality of life was deteriorating. After just that first session of removing some of that cerebral spinal fluid, she was able to lift up her head. She was engaged, alert, and conversed with them and was able to eat and function normally. So again, the process would be to remove more of that cerebral spinal fluid, but that is a reversible type. So that's an example. So it typically affects people in their 60s and 70s. These are some of the symptoms that's correlated with normal pressure hydrocephalus. So difficulty walking, that's sometimes compared to the way persons walk. Like on a boat, it just, you can see there's a difference with regards to their gait. Decline in thinking skills. So overall slowing of thought processes, apathy, impaired planning and decision making, then that loss of bladder control. So brain disease related to subdural hematomas. So what is subdural hematomas? It is a collection of blood between the covering of the brain, the dura, and the surface of the brain. It is most often the result of a severe or minor head injury, which is common in the elderly after a fall, which we've seen, right? They're more likely to fall. I don't know the statistic on that, but so some of the symptoms regarding chronic subdural hematomas are related, or subdural hematomas are correlated or related to those who have traumatic brain injury, right? So dementia due to head injury is comparably rare and accounts for less than 5% of cases. So a lot of people ask, with the subdural hematoma and having that traumatic brain injury, what is your likelihood of developing a form or type of, dementia? So it's very rare. Again, it only accounts for about 5%. Traumatic brain injuries affect an estimated 2 to 3 million people in the United States each year. So between 400,000 and 500,000 people are hospitalized. And it is difficult to find accurate statistics on how many people with TBI go on to develop a significant dementia. But there are areas that we can consider that can help us decide whether or not that affected their brain enough to where it would develop a former type of dementia. But it's such a controversial topic right now. There's a lot of research going into that, especially with athletes, and you see with helmets and research with regards to that. And oftentimes we see football players with more or less that frontotemporal part of the brain affecting their cognition and their ability to function with their activities of daily living. So some of the symptoms are apathy, confusion, lethargy, memory impairments, and then difficulty completing their activities of daily living. So delirium. So what is delirium? Delirium is a serious disturbance in mental abilities that results in confused thinking and reduced awareness of your environment. The start of delirium is usually rapid, within hours or a few days. So typically, what ends up happening with those people who have that confused, the acute confused state of mind is that they go misdiagnosed. So I wanted to read this study or statistic that I found with regards to delirium. So 10% of elderly patients who are admitted to the hospital have delirium. So 10%. About 15 to 50 experience delirium at some time during hospitalization. So they go in, about 50% have them, but once they're hospitalized, it increases up to 50% of individuals who are showing signs of delirium. So this is also common after surgery. You see that with those who are under anesthesia and among nursing home residents and ICU patients. I actually had one gentleman, sad story with regards to anesthesia, and I mention this only because it affects every person differently. Well, this individual had been showing some memory decline, nothing super significant to where, he couldn't still, work or do his activities and participate and engage. Well, he had to have surgery and he had to have anesthesia. So after surgery, he had that fog brain with anesthesia, which typically is like 1 to 2 weeks. Some people it's just a couple hours or days. Well, it ended up lasting several months. Like 1 to 2 months. And he was just concerned, like, why, the family members were like, what's going on here? He's just not coming out of it. What ended up happening was, in his case, it actually increased the progression of his disease process. He had Alzheimer's disease, and having anesthesia just progressed it to where he was at that state, and there was nothing they could do to reverse it. He was at that state. So, but you have to be wary of understanding, okay, what is delirium versus what is, part of this disease process? Because most oftentimes they go misdiagnosed. They could just have this acute confusional state and they're diagnosing the older adult. If they go into the hospital, they can't tell you, what medications they're on. I'm pretty sure if they're taking 10 or more, 5 or more, I wouldn't even be able to tell you what medications I'd be on. You're stressed, it's a stressful environment. And so there's a misdiagnosis there. And oftentimes, if it goes unresolved, the person might automatically just develop a former type of dementia because they're misdiagnosed. So just to keep that in mind. So this next slide was just for your information of an acronym with regards to delirium and what could cause it. It could be drugs, electrolytes, so dehydration, lack of drugs, infections, reduce of sensory input, so hemorrhage or stroke, urinary problems, or heart attacks. So I just wanted to include that in there in your handout. So these are the symptoms. We've already discussed them. So sudden onset over hours to days, reduced awareness of the environment, poor thinking skills. So that could cause that disorientation that you see. That's very common, especially among older adults. And then behavior changes. So persons who are delirious too can have those visual hallucinations. So automatically you label them as, this person's showing signs like Lewy body dementia, and then there's that misdiagnosis. So just understanding those differences. And then there's also emotional disturbances. This could be, anxiety. This could be fear or paranoia. Those as I go back with regards to Lewy body dementia, I had an individual whose mother kept hearing a buzzing sound throughout the house. So they had the exterminator in, they checked all the pipes, they checked everywhere, and there weren't any bees or anything that was going to attack her. But she continued to show this behavior and display this behavior, like there's a buzzing sound, and she would have all of this anxiety, she would have this paranoia. And the daughter didn't know what to do. What do you do in those circumstances? How do you handle those situations? So with this disease, it's all about trial and error. Sometimes it works, sometimes it doesn't. You have to try it and then just move forward. So the bottom line is what we ended up doing was we got her a spray bottle and we had her fill it with water. And so anytime she could, she could hear the sounds and the buzzing sounds getting closer, we just told her, just spray it with water and it'll, eliminate that. It will kill them. And so they ended up doing that. Water doesn't harm unless she's like pouring it out, but so that alleviated that behavior. So you just have to be creative. That's just a side note. So depression, what is depression? So depression is a brain disorder affecting your thoughts, emotions, behavior, and your overall physical health. So persons who have depression often show these signs or symptoms. So loss of interest, social withdrawal, memory problems, sleeping too much or too little, and impaired concentration. If I didn't have the header as depression or the symptoms of depression, if you just saw loss of interest, social withdrawal, memory problems, sleeping too much or too little, impaired concentration, would you perhaps misdiagnose this individual as maybe having dementia? Some do and some don't, right? So depending on the severity of their depression and what occurs, that's where that misdiagnosis happens. I had one couple, and I like to tell you stories so you can understand a little bit more how this works. The wife, well, first of all, they decided to retire. They had bought an RV and they had a map and a plan to travel the country. And upon the retirement of the husband, she started to notice some cognitive decline. And she was really concerned, even with his memory. She would tell him certain things he couldn't recall, he'd forget. He just wasn't as reliable as what she was used to. So she decided to see her primary care physician. They did all the exams, the mini mental status exam, some blood work, and a CT scan just to kind of see, okay, what's going on? Well, they came up with the diagnosis of Alzheimer's disease that the husband had. He's showing early signs of Alzheimer's disease. She was devastated, didn't know what to do, wasn't educated on the disease, so she ended up reaching out to the Alzheimer's Association and joining a support group. So in her first initial support group meeting, I was the facilitator, she shared her story. So the group for the whole hour focused on her and asked her questions. Could it be a reversible type of dementia? Did your doctor really go over the family history? Has he ever been diagnosed with depression? So on and so forth. So they ended up being the advocate for her, right? And asking these questions. So as the group is asking the question and she's answering, she's like, wait a minute, my doctor really didn't ask those questions. Wait, I don't even know if he was tested for that. So then it was suggested, well, maybe you should get a second opinion. You never know. So months go by and she comes back and she thanks the group and she said, thank you so much. So my husband retired as an attorney. He's been fighting depression for 10, 15 years. He's been on medication and he actually has chronic depression. Doesn't have Alzheimer's disease. But if gone, misdiagnosed for Alzheimer's disease, it forms into Alzheimer's disease. This is just a reversible type of dementia. So luckily for her in that situation, he just had depression that he could be on medication for and it was reversed. It wasn't Alzheimer's disease. So what do I mean when I say eye and ear impairment, especially when it comes to our elderly population? What could this mean?
There's a lot of visual things that can happen. You can have spots and kind of not understand the spots or shadowing or macular degeneration.
Yeah.
There's a lot of eye
So,
things that can probably promote you to hallucinate or make the
right, you could have delusions with regard to vision impairments. You can, not see what's in front of you, more at fall risks. You might be given like the newspaper that you read on a daily basis and you're not reading it now or you're not understanding it, or you may, there are a lot of things. You might not be eating the food in front of you because you really can't see what's in front of you. And that combined with other, symptoms that are related to a former type of dementia can go along with being misdiagnosed. I don't know the statistics with seniors or older adults who are misdiagnosed who have a vision or hearing impairment, and they diagnose them as having a form of dementia. But oftentimes, the individual who can't hear properly or doesn't understand what's going on, maybe who's asking those repetitive questioning, maybe it's not the deterioration of their hippocampus. Maybe it's because they really can't hear you, and that's significant. So I wanted to mention something. So visual impairment is the functional limitation of the eyes, whereas hearing impairment is the partial or total inability to hear. So I wanted just to read this to you. So gradual hearing loss is a common symptom of aging. But in some people, it may also be an early sign of Alzheimer's disease or other types of dementias. So the risk of dementia appears to rise as hearing declines. Older people with mild hearing impairment, so those are individuals who have difficulty following conversation in crowded restaurants, say were nearly twice as likely as those with normal hearing to develop dementia. So that's what this particular study found. And I was really focused on hearing impairments and, how can that cause a former type of dementia? Because my father refuses to get a hearing aid. And I did this research diligently to prove and show him statistics that prove that with hearing loss, as it progresses, it increases your likelihood of developing dementia. Why is that? Whatever those wavelengths and things that are going, that go to the brain and you process are not being used anymore. So it's literally like you're killing your own brain cells by not addressing that hearing loss. I know that's more blunt than you would like to address it, but you just have to be firm. And if you care about somebody, or if you know of somebody who has that hearing decline, you want to encourage them to see an audiologist. You want to encourage them to get on hearing aids. And I know it's a huge expense, but I would much rather pay, a couple $1,000, $3,000, whatever it may be for hearing aids than having to deal with this disease process that only progresses. So I wanted just to read that statistic to you with regards to hearing impairment and hearing loss. So it goes hand in hand with that mental functioning and that decline. And we also know that without being able to hear and communicate, it creates a whole nother issue known as social isolation. And we know that isolation isn't the best medicine for persons who are aging, period. So some of the symptoms are recognizing people, difficulty finding things, locating food on their plates, struggling with following a conversation, social isolation. Another thing I want to mention to you too, those who do have the diagnoses, if you find that they're not eating the foods that is put in front of them, for example, I know most of you are social workers or nurses, what tends to happen is that they become very overwhelmed with what's in front of them because they don't understand what each food type that you put in front of them is. So you want to reduce what you're presenting to them. Maybe it's by stage. First you give them a salad and you kind of help them out throughout that process, because sometimes they get super overwhelmed. So they see the plate and they just move it away because they don't know where to start or what to eat, or the quantities are too large. So that's just a little fun fact as well. So infections, urinary tract infections and pneumonia. So what is a UTI? UTI is an infection in any part of the urinary system, the kidneys, bladder, or urethra. It can exacerbate dementia symptoms. So typically, if somebody does have a diagnosis of Alzheimer's disease and you see a sudden decline in their cognitive functioning, you want to make sure that they see their physician, because it could just be a UTI as well. And a lot of older adults, men and female and women, have UTIs. So a lot of individuals feel that, it's their gender bias, that it's majority women. Yeah, majority women do get UTIs, but so do men. So just being mindful of that when you see that sudden decline.
And may I add?
Yes.
Bladder pain, it can often be not symptomatic with the older adult. So it's not unlike when you're in your 40s and 50s and you've got bladder pain.
Right. Yeah,
The
bladder
over
pain.
75 crowd, it's rarely in the symptoms.
Right. Yep. So then that's a good point to bring to light as well. Usually individuals who are older and who have the diagnoses too, they're unable to sense the pain or to really relate or share with you that they're in pain. So bladder control, all of that bladder pain, they're unable to really share with you what's really going on. So this is where if you guys were participating with the geriatric lecture series last week, there were some really neat tips and tools as to how to address behaviors as they occur. And we encourage behavior only because that way, that's our form of communication with them. So when a behavior occurs, it's them telling us like, well, something's wrong, and we have to be that Sherlock Holmes, and we have to investigate what's going on. What are they trying to tell us? What's hurting them? So some symptoms of UTI are those sudden confusional states like delirium, agitation, withdrawal, change in behavior. So again, very similar to those who have a form of dementia. Pneumonia is the inflammation of the air spaces in the lungs, most commonly due to an infection. So aspiration pneumonia, or as I mentioned earlier, is the cause of death, typically for persons who have this type of disease. So some of the symptoms, the same thing. So deliriums, confusional state of mind, dementia, fatigue. So I jumped there. So what are some metabolic disorders? So it can happen when abnormal chemical reactions in the body alter the normal metabolic problem. So what is the function of our metabolism? What is that control? What is our thyroid control? What does that do? What is its function? Heartbeat, body temperature, right, pretty much how we function too. So when that's askew, what can that cause? It could cause all of the states of confusion that we just mentioned, with delirium, with memory impairment, with the way that you interact, the way that you talk, your seclusion. So you want to be mindful of your thyroid as well. Oftentimes we share that you want to get the full panel T-test to make sure that the levels, your thyroid levels, are normal. So it's like a panel, it's like a T4 test. There's T1, T2, and T4. So you want to make sure that that panel is addressed, because typically what they do, they just give you like a generic thyroid exam, and most of the times it shows that it's normal. So you want to make sure that you address it. And the only reason why I speak on that is I had an individual whose husband was diagnosed with cancer, and she was treating the cancer. He survived cancer, went through chemo, 7 years of being a caregiver of a cancer survivor eventually. Well, then she started to see like the cancer brain occur, where, that fogginess, he wasn't able to speak properly, he wasn't able to communicate, he wasn't really able to do most of his activities of daily living. So they thought, well, maybe this was a side effect from his treatment. Well, it only started to progress more. So then she went to see the physician, her primary care physician, and they diagnosed her husband then with early onset Alzheimer's disease. And, that was devastating for her. But she started to do her own research and read more. And she said her husband's father had some issues with his thyroid. And so she kept pushing to have a full panel test done and to really research more on his thyroid, that I think that his levels are askew and we can address that with medication. Well, they said, no, we've done the test already. He's normal. The levels are normal. So there's really nothing that we can do at this point. He has the diagnosis of Alzheimer's disease. For 5 years, this wife advocated for her husband. It got to the point where she was unable to, or he was unable to bathe himself, to go to the restroom. He was incontinent. And she had issues of her own too. She had arthritis. She, had other physical ailments as well, along with being the primary caregiver of her spouse. Finally, she went to another physician. She had gone to several, and this physician actually listened to her, and they did the full panel T-test and found out that his levels were way out of whack. Like unbelievably out of whack. And so they addressed that. They gave him medication to help with that. And initially, it did help a little bit. He was able to form some sentences and communicate with her. He was able to actually feed himself, and she didn't need to assist him as much with, his toileting and bathing. However, he had been diagnosed with Alzheimer's disease for 5 years, that it was only progressive. So these medications only helped out for a little bit, but it was only going to get worse. So in that case, that wasn't the happy story of where it was caught earlier enough could be reversed. So these are some things that can happen. You want to ask the questions. You want to make sure that the physician that you see or you recommend to your clients does all of the testing related to these reversible signs of dementia, the blood work, the blood tests, the CT scans, the family history, asking all those questions to make sure before they give you or give them that diagnosis that it's not a reversible type of dementia. Is there a question?
I do have a question about that. That comes up a lot with my patients, and sometimes they have a diagnosis already, sometimes they don't. And I refer people to neurologists.
Right.
And sometimes even psychologists or psychiatrists, if there's lots of behavioral stuff. But I feel like sometimes the primary care doctors, they have a lot of basic information, but to get to the specifics,
Right.
I don't know if is that appropriate or
So, so the question was, so the question here was, so most oftentimes, it's recommended that you go to your primary care physician, because in order to see a specialist, you need that referral. So in order to go to your primary care physician, you can then request, I want to see a neurologist because they're the brain specialist and you're concerned about this, right? But oftentimes too, even in that situation, or if you see a psychiatrist or a clinical psychiatrist, depending on the behavioral issues too, you want to make sure that you're comfortable with the diagnosis, because even those specialists don't go through all the testing. So you want to make sure you have to be educated, and that's why these trainings are so valuable too, so you can help those clients that you're dealing with. Like, here's a sheet of reversible types of dementias. You ask your doctor or the specialist, are you going to test for all of these things to make sure that my loved one doesn't have these types of, disorders or things that can be reversed, versus giving them that label of Alzheimer's disease or a form of dementia. So some of the symptoms with regards to metabolic disorders are inability performing simple tasks, getting lost, misplacing items, changes in mood and personality, loss of social skills. And another thing too you want to keep in mind is, if an individual, if you hear one of your clients share that their loved one is taking a lot longer to, go from the grocery store and back, and sometimes they don't always bring back the items that, I'd asked them. What tends to happen too is that with the warning signs, losing that time or place, they forget where they're at. They forget how to get home. They forget that, how to get to the senior center, which they go to every, lunch hour. So that's another warning sign as well, and being mindful. So what is malnutrition? So it is the condition that develops when the body does not get the right amount of vitamins, minerals, and other nutrients it needs to maintain healthy tissues and organ function. So undernutrition can lead to delayed growth or wasting, while a diet that provides too much food but not necessarily balanced leads to obesity. So according to the World Health Organization, malnutrition is the gravest single threat to global public health. So dehydration. Dehydration occurs when you use or lose more fluids than you take in, and your body doesn't have enough water and other fluids to carry out its normal functions. If you don't replace the lost fluids, you will get dehydrated. Oftentimes, for those older adults, they don't feel thirsty as much anymore, so they've lost that thirst sensation. So you want to make sure that they're hydrated, especially during the hot months of the year as well, because this could cause states of confusion, disorientation, depression, changes in mood, and their risks of falls. And oftentimes persons feel that as you get older, you do not need the same water content as you did when you were younger, and that's a myth. They need just as much. The only problem is A, they've lost that thirst sensation, and B, they don't want to use the restroom as much anymore. So that's what causes them to be dehydrated. As we all pause and drink some water, excuse me. That conversation just made me very thirsty. So vitamin B12 deficiency. So I know most of you have heard this with regards to research that's been going around with regards to Alzheimer's disease or forms of dementia. Oftentimes, those who show vitamin B12 deficiency mimics. It's very similar to somebody who has Alzheimer's disease. So what is that? So anemia or nervous system injury from lower than normal amounts of vitamin B12. Vitamin B12 is a nutrient that helps keep the body's nerve and blood cells healthy and helps make DNA, the genetic materials in all cells. Low vitamin B12 levels may be to blame for some of the cases of poor memory and cognitive decline in the elderly. And B12, vitamin B12 is found in meat, fish, eggs, and dairy products. So that's how you can supplement that, or buying the vitamin, over the counter, or you can do the shot as well. So these are some of the symptoms. Weakness, confusion, depression, memory loss, and behavior changes. So adverse reactions to medications. So this is an injury caused by taking several medications at once. May occur following a single dose or prolonged administration of a drug or from the combination of 2 or more drugs. Who here in this room in Reno has dealt with clients who are who are prescribed 5 or more medications? So for those of you who can't see them, that was at least 95% of them rose their hands. So what is your understanding of adverse reactions to medications? What are some of the symptoms that one can display if they're taking more than 5 medications? Hallucinations, depression, not thinking clearly, duplicative medications for several doctors, correct. So typically what we see is that there isn't communication between doctors, physicians, specialty physicians, whatever it may be. When I worked, I did my master's with an adult geriatric psychiatrist, and he was one to always reduce one's medications, and he, again, focused on geriatric patients. And I had a gentleman who was over the age of 65, and he was taking 3 medications, and this was over the counter too, just 3. Well, he took a fall and he fractured his hip. Several months passed. He went through physical therapy, so on and so forth. But the family was just sharing, I don't think he's recovering well. Could it be possible that he hit his head during his fall that could cause dementia and that progression? So they came back. After the appointment, the doctor came out and just threw his chart on my desk and just said, unbelievable. And I said, okay, what happened? He goes, I want you to pull out his medication list and count how many medications this gentleman is on. And I said, okay. So I counted them because I had to input them too. So just because of a hip fracture and having to see different physicians throughout months and months, what do you think the amount of medications this gentleman was on? And this was over the counter as well, and then prescribed medications.
Say like 30.
Yeah, 27. I had heard from another previous lecture that they had, a person had seen 7 different physicians, and they were prescribed 40 medications for this one individual. So, I mean, and you wonder why, they have this memory loss, cognition problems. It's all these adverse reactions to the medication. So what I want to share with you is there is a resource, unfortunately in Las Vegas, I don't know if they have it there, but there's a resource here in Reno at our Sanford Center for Aging, the Medication Therapy Management Program, that those who are 60 years and older can apply for, and they see a geriatric pharmacist who goes over their medication. There is a qualification for that, especially with income, but typically they won't turn anyone away if they need the help in the service. We also have our comprehensive geriatric specialty clinic. So they get to be seen by a geriatric pharmacist, a geriatrician, and a social worker. And they do a comprehensive assessment as well here locally. So we just mentioned these symptoms: short-term memory loss, disinhibition, and hallucinations. So the next couple of slides are just some local resources in different areas in Nevada, such as Elko. You can go to the links there, in Winnemucca, those who are signing in or logging in from Winnemucca, Pahrump, Mesquite, and Carson City. I know that with Pahrump, the Royal Pages is also resources in Las Vegas as well. So that is very similar to our Golden Pages here in Reno. So geriatric care. Is everybody familiar with what geriatrics is and what that specialty defines, or what it focuses on? So gerontology is the study of aging. Geriatrics is the medical and biological aspects of aging. So that's why we have geriatricians who focus in medicine. So geriatric care is the process of planning and coordinating care of the elderly and others with physical and or mental impairments to meet their long-term care needs, improve their quality of life, and maintain their independence for as long as possible. And a geriatric physician, a geriatrician, is a physician who specializes in the care of older adults. Primary care, we're all familiar with what a primary care physician is. It's the day-to-day health care given by a healthcare provider, and the primary care physician is a physician who provides both the first contact for a person with an undiagnosed health concern as well as continuing care of varied medical conditions. So your primary care physician can also give you the diagnoses of a former type of dementia, but if you wanted like a second opinion or if you wanted a specialty doctor, that's where you can request to see a neurologist. Are there any questions? Here in Reno, I'm going to ask Reno first with regards to the first half of our presentation. No? Is there anyone in Las Vegas? And then is there anyone in Zoom? You can type that in there. Nope, nobody in Zoom. Okay, so we're going to take a 15-minute break. So we're going to reconvene at 2:45. Stretch break, drink some water. We'll be back. Everyone. Before I move on to the next topic, I wanted just to touch a little bit more with regards to Alzheimer's disease and the onset of Alzheimer's disease. I forgot to mention that those who are diagnosed with this disease can live anywhere between 4 to 20 years. Current research has shown that you can live up to 30 years with this diagnosis. Oftentimes, too, I've been asked, well, what do you do or what happens? How do you prevent it? So there is no sort of prevention of Alzheimer's disease or forms of dementias, but what you can do is delay its onset. So what does that look like? Well, a healthy lifestyle, healthy diet, exercise, brain games. So persons who are educated, you might feel, and I've had this question before in class, well, you know, I know somebody who's highly educated and they got diagnosed right at like 65 years old. How is this possible? Well, typically then for that individual, they might have had younger onset Alzheimer's without the education. So what ended up happening because of the level of education, the onset was delayed, 10, 15 years. Because once you start seeing those 10 warning signs, if it's not something that could be reversed, that once somebody physically sees it, it had already been established or developing 10 to 15 years prior to actually physically seeing it. So they had been developing it after, over all these years. So I just wanted to mention that part of it too. There isn't a magic pill, but there are things that you can do to delay its onset of developing Alzheimer's disease and other forms of dementias. So in going on to our next topic, this topic was brought to the Nevada Geriatric Education Center's attention when we did a questionnaire regarding what topics are of interest out in rural areas. And so one of which was hoarding. So I am not an expert in the field of hoarding. I had to work with the project, is it the Hoarding project, to come up with this PowerPoint presentation and kind of teach myself and help myself understand what are the differences with their collaboration and help as well. So I just wanted to preface the second half of this training that I'm not an expert. There may be things that you might ask. I will try to my best ability to answer those concerns or questions you may have. But here we go. Let's get started. So the topic is when too much is not enough, recognizing and understanding hoarding. So the learning objectives for this second half is to differentiate between clutter, collecting, and hoarding, because they are all different facets with regards within each one. Review implications of hoarding and potential resources. So that's it. That's the learning discussion. I had one more. Sorry. My tone ended as if there was a third one to follow. And just being excited about hoarding. That's the overall scope here. So what is clutter? Okay, it's my house. So what is collecting? My house. Okay, so people have, yeah, purposeful. All right. What is hoarding? Uncontrollable collections of every single item, right? Just, yeah, clutter to the extreme. Okay, so we're going to go over these in a little more depth and a little more detail. So what is collecting? So collections differ in a wide variety of respects, most obviously in the nature and scope of the objects contained, but also in the purpose, presentation, and so on. The objects may be antiques or simply collectibles. Collecting is a childhood hobby for some people, but for others, a lifelong pursuit of something started in adulthood. So collectors who begin early in life often modify their aims when they get older. Some novice collectors start purchasing items that appeal to them, then slowly work to learning how to build the collection, while others prefer to develop some background in the field before starting to buy particular items. So typically, these items are worth money, and there's something that the person is proud to display. This is what collecting looks like. So collectors typically keep their possessions well organized, and each item differs from other items to form interesting and often valuable groupings. Furthermore, an important purpose of collecting is to display the items to others who appreciate them. Items do not take over living spaces, and items usually have a positive or pleasurable impact on the individual. Collecting usually does not cause financial distress, nor impairment in work or social life. So that's collecting. What is clutter? Clutter is defined in the Diagnostic and Statistic Manual as a large group of usually unrelated or marginally related objects piled together in a disorganized fashion in spaces designed for other purposes, such as tabletops, floors, hallway. While clutter is the most easily visible marker of hoarding disorder, a home can be cluttered for a variety of reasons. Hoarding disorder is only considered when the clutter results from excessive acquisition and difficulty getting rid of things. The location of the clutter is also an important factor. It is common for most people to have cluttered storage areas, such as basements and attics. Instead, hoarding disorder involves clutter that takes over all of the living spaces of the home, such as the kitchens, the living room, the bedrooms, the hallways, and it keeps them from being usable for everyday living. So the thought of getting rid of items or not acquiring any more does not cause distress with persons who clutter. So this is what clutter looks like. So people have a very different idea of what it means to have a cluttered home. For some, a small pile of things in the corner of an otherwise well-organized room constitutes serious clutter. You know, somebody who has obsessive compulsive disorder, right? So for others, only when the narrow pathways make it hard to get through a room does the clutter register for them. So to get an accurate sense of clutter, the clutter problem, the International OCD Foundation created a series of pictures of rooms in various stages of clutter, from completely clutter-free to very severely cluttered. People can just pick out the picture in each sequence that comes closest to the clutter in different areas of the house. So there's a picture of the bedroom, there's a picture of the living room, and there's a scale that they will show individuals, you know, with regards to what level of clutter do you think you're at. So this requires some degree of judgment because no two homes look exactly alike, and clutter can be higher in some parts of the room than others. Still, the rating works pretty well as a measure of clutter. In general, clutter that reaches the level stated on picture 4 or higher impinges enough on people's lives that it is encouraged of them to seek help for their hoarding problem. So persons can have clutter in their home, and the difference between clutter and how it transitions into a hoarding disorder is if the rooms aren't functioned for those purposes. As I mentioned, like the kitchen, the bedroom. So they can no longer cook in their homes. They have difficulty even walking and getting into the bathroom. Their bathtubs are filled with items. That is where the hoarding disorder starts to appear. So I'm pretty sure each and every one of us, no matter how OCD we may feel we are, I'm pretty sure we have clutter, whether it be Christmas decorations, Halloween decorations, but it may be a collection, right? So we neatly organize it. So we're not clutterers, we're collectors of fine, pieces. So that is where I wanted to share with you the difference of what a collection is, or a person who collects versus somebody who, clutters, to where clutter then turns over to hoarding. So does that make sense so far?
It says clutter rating, and those things down there starts looking pretty bad there about number 4. But
right.
Is number 9, that can't just be clutter.
No, that's hoarding. Mm-hmm. Yeah, so from 4 above, that's a good question. Anywhere from 4 above, you have a hoarding disorder. So, below 4, it's just clutter. Because these are still functional spaces. You can still walk to your bedroom. And so we've seen the hoarding shows and what happens there, and we're going to discuss what triggers that, because there is a trigger with regarding to this hoarding disorder. I've actually had, I've helped a client of mine during my free time who actually displayed, which I thought was hoarding, but she was a clutterer. It was just that with the caregiving process and everything, she just didn't have the energy or time to start to, organize her things. Because a person who clutters, they're able to remove things from their home easily. You can just say, okay, I have duplicates of this, I can remove this, I don't need this, and start to organize it. Persons who tend to hoard, you cannot remove anything from the home. Every single thing that's there has a meaning, a meaningful sort of connotation to it. So we'll discuss that in more detail here. But I wanted to give you some visuals so you can kind of see. So what is hoarding disorder? So hoarding disorder is a pattern of behavior that is characterized by excessive acquisition, an inability or unwillingness to discard large quantities of objects that cover the living areas of the home and cause significant distress or impairment. So what is excessive acquisition? So excessive acquisition is defined by the American Psychiatric Association as the excessive acquisition of items that are not needed or for which there is no available space. So excessive acquiring and refusing to discard items results in disorganized piles of stacked of items such as newspapers, clothes, paperwork, books, or sentimental items. I know that a lot of social workers see this when they go into the homes. I had one social worker share with me that there was literally just that hallway, and it was from floor to ceiling of magazines and newspapers. The bathtubs were filled with things, and we'll talk more too about animal hoarding as well, because they were collecting of animals too in the home. Possessions that crowd and clutter the walking spaces and living areas and make space unusable for the intended purposes, such as not being able to cook in the kitchen or use the bathroom to bathe. buildup of food or trash to unusually excessive unsanitary levels, significant distress or problems functioning or keeping yourself and others safe in their home, conflict with others who try to reduce or remove clutter from the home. My dad had shared a story with me that my great aunt was a hoarder. And it was so awful because she didn't have access to the bathroom, and she didn't shower. I mean, it was just crazy. So one day they were able to remove her from the home and said, oh, let's go do this fun activity. And she bought it and they left. And so a bunch of them came into the home, and they didn't feel that they could remove or throw away, discard the items. So they just stacked it in the barn, which is a big mistake, because in them stacking it in the barn, and when she got home, she put it all back in the house. So, because for her, maybe the clutter was a sense of security, right? So, difficulty organizing items, sometimes losing important items in the clutter. People with hoarding disorder typically save items because they believe these items are unique or will be needed at some time in the future. You know, you often wonder, well, how many can openers do you need? Well, they would respond, well, you never know. I might be in this side of the house, I might be in that side, and I need it everywhere. So these are some of the questions that you might ask them. The items might also have an important emotional significance to them, which is why they keep it. Maybe serving as a reminder of happier times or representing beloved people or pets. And then they feel safer when they are surrounded by the things that they save. They don't want to waste anything, is the mentality. So how is the individual affected once they are diagnosed with the hoarding disorder? So they have difficulty managing daily activities. So getting and saving an excessive number of items gradually build up of clutter in living spaces, and difficulty discarding things are usually the first signs and symptoms of hoarding disorder, which often surfaces during teenage to early adult years. Some research has even shown that it's shown in childhood. You know, the person or the child that saves their, stuffed animal, their blanket, that's their favorite blanket, that's what they slept with. Some have saved like the pencils that are all down to here. And so you see it in childhood, but it's not as prevalent because you have parents who dictate and share with you, like, you need to clean your room, you need to do this. So you don't really see hoarding as a problem. But as they get older, you see it develop more and more. And it could just, be a collection, or it could be, some clutter, or it could turn into a hoarding disorder. So as the person grows older, he or she typically starts acquiring things for which there is no immediate space or need. By middle ages, symptoms are often severe and may be harder to treat. So problems with hoarding gradually develop over time, and it tends to be a private behavior. People don't really notice that or see it. Often, significant clutter has developed by the time it reaches the attention of others. So how does this affect the person with hoarding disorders? So it becomes difficult for them to manage daily activities. They tend to procrastinate and have trouble making decisions, limited or no social interactions, like isolation, perfectionism, worry about making the right decision about what to do with each possession, excessive attachment to possessions, and discomfort letting others touch or borrow their things. So some hoarding statistics. Understanding the age of onset of hoarding behavior can help develop methods of treatment for this impairment. So hoarders pose dangers to not only themselves, but to others as well. The prevalence of compulsive hoarding in the community has been estimated at about 2 to 5%. So about 15 million Americans has been diagnosed with a hoarding disorder. So this is significantly higher than persons or rates of OCD, panic disorder, schizophrenia, and other mental disorders. The condition, as I mentioned earlier, typically manifests in childhood with symptoms worsening in advanced age. So hoarding appears to be more common in people with psychological disorders such as depression, anxiety, and then ADHD, attention deficit hyperactive disorder. Was there a question?
I'm just kind of surprised at this. I feel like hoarding is a symptom of anxiety or depression or something else. So it's kind of interesting that number is so high in normal diagnosis.
Yeah, so I mean, just because of the research that has been done with regards to hoarding and comparing it to other mental disabilities, you know, because it's become more prevalent and more significant, you know, that's why they deem it more a disorder versus a behavior that could attribute. But they do say that it could be attributed to the anxiety that is caused, or, you know, depression or whatever it may be, that they would then start to hoard. So it's sometimes pot or kettle in the sense of what started that. So let's see here. The condition typically manifests in childhood. We just mentioned that. More common in people with psychological disorders. And the statistic here is that compulsive hoarding does not seem to involve the same neurological mechanisms as more familiar forms of obsessive compulsive disorder, and does not respond to the same drugs with somebody who's diagnosed with OCD, which target serotonin. In compulsive hoarding, the symptoms are presented in normal stream of consciousness and are not perceived as repetitive or distressing like in OCD patients. So despite statistics indicating that there is a prevalence of hoarding in 18 to 40% of patients with OCD, only 5% of compulsive hoarders experience the symptoms of OCD. So when we're talking about those who have an issue with hoarding animals, what tends to happen is that it involves them keeping larger than usual numbers of animals as pets in their home without having the ability to properly house or care for them. So compulsive animal hoarding can be characterized as a symptom of a disorder rather than deliberate cruelty towards the animal. They don't realize that that's what they're doing. They're just hoarding. It's just a behavior that they're collecting these animals, not understanding. There are about 700 to 2,000 new cases of animal hoarding per year in the U.S. Hoarders who collect animals live in filthy and unsanitary conditions. 60% of animal hoarders' homes have animal feces and urine on the floor. You know, some even have the pets that are deceased on the floor. And I actually, I was talking to a social worker. We have interns at the Sanford Center for Aging, and she experienced this out in the field. And she said, I had one that was just horrible. I mean, I couldn't even sit on the couch. There were feces on the couch. The smell was just so horrible. And then she said that the individual couldn't even remove the feces. Like, she would put them in baggies and keep them in the home. Like, even discarding that was hard for her. So she kept it. So, I mean, it is a disease and it is a disorder. So, and it varies for each individual. So, hoarding and older adults. Has anybody here in Reno gone into a home where it was, you know, that because of the hoarding show that came on with A&E, that's why the numbers had increased significantly, because there was more awareness, more education on it. And she also, a person here shared their story with regards to a person who had been hoarding animals for 20 years, and their subflooring was rotting. They could see the crawl space, and the oxygen levels were 20%. So for people to even enter the home, they had to put on oxygen masks in order to even, you know, function in the home. So the severities of hoarding is very prevalent. So with hoarding in older adults.
Before that show came on, when we social workers would go out to these homes, and you would be so shocked.
Mm-hmm.
You couldn't believe, like she said,
yeah, so
couldn't even walk. It'd be a little tiny space.
Yep. So before
feces, and they wouldn't want you to clean or touch it.
Yep. So before the show even came to light, you know, persons who first saw it firsthand were those social workers going into the home and just in shock and disbelief, like, what am I entering into? You can't even, I mean, I know that the one social worker, what she shared with me, she's like, I couldn't even go back to work. I had to excuse myself and go take a shower and take off my, you know, like, just to discard it because it smelled so bad she couldn't function the rest of the day. So,
Well, maybe add bed bugs to the mix.
and then bed bugs, yep, and coming into the home. So there are a lot of negative connotations to hoarding. So with hoarding in older adults, significant health, safety, and functional consequences have been found in older adults meeting criteria for hoarding disorder. Among elderly patients aged 61 to 97, 25% of senior daycare participants and 15% of nursing home residents exhibited hoarding-related symptoms. Hoarding disorder can have serious consequences for older adults, such as increased risk for falls, fire hazards, poor hygiene, poor nutrition, and medical problems. Other serious consequences of hoarding disorder observed in older adults include food contamination, social isolation, and medication mismanagement. So, let's see here. So I wanted to read this one study, what they investigated. So one study investigated self-reported medical problems in older adults with hoarding disorder, found that there are substantially higher rates of self-reported conditions, about 90% in older adults presenting with compulsive hoarding problems, that in older adults with hoarding disorder, about 44% have. Medical conditions that were the most common for older adults with compulsive disorder include cardiovascular conditions, such as hypertension, which accounted for 61%, stroke, which accounted for 11%, sleep apnea, which accounted for 22%, and seizures, which accounted for 11%. So there may be also an association between hoarding symptoms and daily functioning. Caseworkers reported that older adults with hoarding symptoms, and this was as determined by the caseworker, were unable to use basic appliances, essential rooms in the house, and had significant plumbing problems. So they found, these caseworkers in this study found that over 80% of patients having hoarding symptoms experienced substantial impairment of movement throughout their home. 70% were unable to use their sofas. Over 50% could not prepare food in their home. And 45% could not use their refrigerators because the stacks were so high. 42% could not use their kitchen sinks. 42% again could not use their bathtubs. 20% could not use their bathroom sinks. And 10% could not use their toilets in this study. Right. So hoarding behaviors occur in about 15 to 49% of dementia cases. In nursing homes, people who hoard had fewer diagnoses and impairments. So what causes hoarding? So according to the Mayo Clinic, at this time there is not a clear reasoning as to what exactly causes hoarding. However, they found some commonalities among hoarders. With regards to age, while severe hoarding is most common in middle-aged adults around the age of 50, their hoarding tendencies began around the ages 11 to 15. So during these early teenage years, they typically save broken toys, as we mentioned, outdated school papers, and pencil nubs. With regards to personality, oftentimes hoarders struggle with severe indecisiveness and anxiety. With regards to genetics, although hoarding is not entirely a genetic disorder, there is some genetic predisposition involved in the disorder. And with regards to that, so I read a story as I was researching this some more, and there was this girl who was sharing her childhood, and she said that her mother was a severe hoarder, but she liked collecting beautiful things, but it would just be in stacks. It would fill up the bathroom. But for her, that was her norm. As a child being raised, she thought that everybody's house looked like this, because when she went to grandma's house, grandma was also a hoarder, grandma and grandpa. So the places, her common places, she saw that, the collection of things and, the clutter, and just found it normal. It was only when she was in junior high, when she invited a friend over, did she finally realize that this wasn't the norm. when she went back to school the next day, she was teased about, what awful home that she has and how could anybody live or survive in that. So she ended up being a counselor. I don't know if it was, I forget what kind of counselor she ended up being, but she ended up helping her mother understand that this is a disease and what started this, what triggered this hoarding. What did grandma do? Because obviously, I'm genetically predisposed, but she said she went the whole other way. Now she doesn't have anything. Her house is bare, because she was just, embarrassed growing up with all the clutter. So she didn't want to kind of fall in that same sort of situation as her parents or her mom or her grandparents. So trauma. Many hoarders experience a stressful or traumatic event that propels them to hoard as a coping mechanism. As I was providing this training, I heard the person shared a very sad story. She informed me that she was very close with her family, had a very close family dynamic, and at the age of 30, her parents got into an accident and both died in the accident. So she was very close then with her grandparents, who kind of, she was already old enough, in her 30s, but she was very close to her grandparents. Well, then her grandparents died at a very young age. I want to say a couple of years after her parents had passed. Well, she started to hoard a lot of things. She had a lot of collections of things. Again, it started first in the basement in areas that they really didn't use, the attics. Well, then it started coming up to the living spaces, and it just became like little pathways. And so she said her son had then come in to the garage and was like cleaning out a lot of his things, to help out with the process. And then she says, and I wish that he didn't do that, without my permission, because he got rid of a lot of his things. And the very next day, he was like there for a couple of weeks. And the day after that couple of weeks ended, the son committed suicide. And so then, that was another trigger. So all of these factors attributed to her hoarding behaviors. So there are triggers and things that cause people to hoard. We just, really need to delve in more. That's why with the hoarding shows, as you go in, they just come in and clean it. I think what they need to show is what's being seen in the background and what sort of counseling is being done, with the cognitive behavioral therapy, for them to then not produce or reproduce or, repeat the same sort of hoarding tendencies, because that is what tends to happen. Yes.
I think one thing that I saw as common with all the hoarders that I experienced out in the field was this inability to deal with the loss or letting go of something.
Mm-hmm.
Every single one of them.
Right.
Things that this gave them comfort.
Yeah.
Yep. So dealing.
That's a common thread. And just to add to what you're saying,
Do you want to come up and share? So.
You'll get this. I just want to point out that not all of this is, categorized as people like being poor, uneducated, and funky environment. I had a woman who was a compulsive shopper. She was a nurse. She was educated. She had a good income. She was still working. And 2,000 square foot home. This was in the Northwest.
No, I might just have you go because it's.
Anyway, she was a shopper. She was a compulsive shopper. Okay. And shopped herself right into the backyard. At the cooler, chair, would live in the backyard. Well, that's just another form. Macy's bag and stuff was still there. I mean, stuff wasn't pulled out to like, I'll wear this, and they've seen it before.
So typically,
it's a compulsive shopper, so just another spin on.
Yeah, because not all of them, like you say, are filthy or dirty.
Right.
Some of them,
right.
You walk in, you're amazed because
Dolores?
Yes.
This is Las Vegas, and I know you guys are having a lively discussion.
Yes.
But we can't partake. So
I know. Okay, thank you. Sorry, Natalie. So some of the comments that were made here with regards to hoarding is that it's not always a condition to where, it's ugly, it smells, it's, unsanitary. Sometimes it's just persons who just enjoy that compulsive shopping. And it's just stacks of things that are nice things, but you just don't have the utilization of your space. So it varies for each person. So they were just discussing those different situations and scenarios. So there was, with regards to the hoarding project, they came up with this biopsychosocial model of hoarding to better understand what causes hoarding. So it goes over, was it family? Was it the loss? I think that's why hoarding is actually more prevalent in older adults, because their sense of loss, that's their way of coping. That's their coping mechanism. You might see it in early childhood, but as you get older, it's more prevalent because that's, people have different coping strategies. So it could be due to family and socialization, communities and their biological aspects, the environment, their culture, and psychological aspects of hoarding. So typically, it's all encompassing of all of these things when dealing with hoarding. So with this particular model, hoarding behavior arises from a variety of external and internal variables that are biological, psychological, and social in nature. So we were talking about the family history and genetic link. You are more likely to have first-degree relatives with hoarding, about 12%, or with hoarding symptoms, which is 49%, if there's somebody in your family. And it's just the tendencies, because you see what happened, you feel that's the norm, and it's just something that you just adapt to. Course and progression. Behaviors begin during childhood or adolescence. I know that's repetitive. And then brain functioning differences. So the occipital and frontal lobes. You see abnormalities in these areas associated with executive functioning. So executive functioning is what? Your judgments, your reasoning. So you see differences with persons who have this disease or this disorder with regards to making those judgment calls. It's not what we're used to. It's not our norm. Impulse control and processing of reward value. For them, when they bring some item in a home, it's rewarding. They're rewarding themselves. And then you trying to remove items in the home or from the home, it becomes more of a fear factor for them. So information processing or cognitive deficits, these are some biological factors. So what tends to happen is with these individuals, their attention, memory, and categorization and complex thinking and decision-making is skewed with regards to how this disease progresses and develops. So whether it be, you might see hoarders that are actually organized. Like this is just all my stacks of magazines, and these are all my stacks of newspapers, and these are all my stacks of trinkets. Or you may see individuals who just throw them everywhere, but they know where everything is. So if you touch it, they know that you've done that. So it's the way that the brain works and how they process it to where how they organize their hoarding or their clutter. Some of the psychological factors when it comes to mental health and emotional distress, it's comorbid mental health conditions and unresolved trauma loss that could cause the hoarding. So that's the psychological contribution there. Bless you. People who hoard have specific beliefs about the attachment of their possessions. So whatever their feelings are towards that object. There might be memory-related concerns or desire for control, responsibility and waste and aesthetics of the home. So this is their own psyche of what they think of when they have this diagnosis. Hoarding behaviors can be reinforced over time. So for them, acquiring things makes them feel good, that reward system. So they want to do more of it. They want to continue it. Getting rid of things makes them anxious. So they don't want to get rid of it. So they don't want less of it. They want more of what they've started to collect. With regards to some social factors, so what are some social factors that contribute to hoarding? Well, major life events and transition. So we were talking about this earlier. So higher frequency of lifetime traumatic events could cause them to hoard. Up to 55% report experiencing a stressful event at the onset of their symptoms. So that's the trigger. People who don't cope well, might turn into, slightly, clutter, that scale from 1 to 3 to 4. and then they just feel even more comfortable with what they're collecting, and then it becomes a hoarding disorder. So burden on families. Positive interpersonal relationships can serve as a protective factor against hoarding severity. So as that story I mentioned earlier, I forgot to add too, because of the hoarding with the lady who lost her parents and then her grandparents and then her son, she also lost her husband, in the sense of she lost her husband in a divorce because he could not handle the hoarding that was going on in the home. So, you having some family members who are educated and understand the hoarding process, can help kind of alleviate the behavior from continuing. So, and this could be cultural things too. Certain cultures, I have a friend whose wife is Thai, and she didn't have a lot of nice things growing up, and he's very OCD, so he kept the clean house. And so now he's just like, there's like bags on the floor that won't be moved, and every time I try to move it, she says, don't touch it. And there's just things that are accumulating, and it's because she's never had these types of things, so she's just keeping every single thing instead of discarding them. So there are those cultural differences as well, and even what era you lived in, right? So there are certain things and certain triggers that, attribute to these hoarding disorders or hoarding behaviors. When it comes to social stigma, some approaches to hoarding disorder on television have displayed people who hoard in a negative and inaccurate way. This portrayal can contribute to the shame and fear of seeking help for both people who hoard and their families, thus making them more isolated. So although I brought it to light that, hoarding is a disease process, it actually hinders the process of persons seeking resources or help because they're embarrassed about it, that there's that social stigma affiliated with it. So how do you address hoarding disorder? You want to ask the question. So these are some questions that you can ask. So are any areas of your home difficult to walk through because of clutter? There is a hoarding rating scale too that's online that you can download. Are you unable to use any parts of your home for their intended purposes? For example, cooking, using furniture, washing dishes, sleeping in the bed. Do you find the act of throwing away or donating things very upsetting? Do you have strong urges to buy or collect free things for which you have no immediate use for? And have you ever been in an argument with a loved one because of the clutter in your home? So I wanted to also share that when I was providing this training out in the rurals, I had the lady who I gave the example of, she had a friend who came with her. And so she then asked the question of, well, how do you know if I'm a hoarder? I said, okay, are areas in your house not being used for its intended purposes? I mean, do you find that a problem? And she goes, well, I started to collect a lot of things in my office, but I had a pathway. I could still utilize it as my office. I could go to my table and type on my laptop and use it. I said, okay, well, now I'm unable to. I said, okay, what do you mean you're unable to use it? Well, the stacks are so high, I can't even get into the room. So I'm now just throwing things in there. All right. So then she goes, but it's just that room. However, I'm going to the guest bedroom because I can't find any more space. So I'm putting some things in there now. Mm-hmm. So I said, okay, so you've already lost one room that, is utilized for a specific, space. It's your office. And you're kind of trickling into another room. You might just want to, address what might be causing this. She says, oh, well, I'm not here for me. I'm here for my friend. She's the hoarder here. So, even they are in denial of what's going on and they don't understand. So I was just trying to help her, know and realize that if it's harder for you to discard the things that you have and you're not addressing what that clutter is, those are the beginning signs. Those are the signs and symptoms of the hoarding disorder. So with asking those questions, you sometimes have to be direct as a social worker. You want to maybe simply state the facts of how this can be harmful to them. Be clear about concerns regarding themselves, their home, as you mentioned, with the subflooring deteriorating because of the hoarding and animal feces, as well as others who might be coming into the home. That's where that social isolation comes in, because they're so embarrassed for anybody to come into their home. They've lost that connection with others. So promote healthy change when it comes to hoarding. So this is before you even suggest for them to see, seek medical help or treatment, with a psychiatrist or whoever it may be. Even their primary care physician they can see them too. It's really hard with regards to resources regarding hoarding. I had asked a psychiatrist who was a speaker, what resources are out there for hoarding, for persons who have a hoarding disorder. And even he couldn't really answer the question with regards to the resources. So my best suggestion for those of you who are going out in the homes and recommending some resources for these individuals, because there are online support groups, they can reach out to the hoarding, even you as professionals can reach out to the Hoarding Project. Jennifer, the director there, is really helpful, and she responds back super quickly and will help kind of navigate and help give you tips and tools regarding, the hoarding rating scale, maybe presenting. They've come up with resources, collateral materials to actually help the person who's diagnosed with or who has the hoarding disorder. Like, this is what's happening, to help them kind of see if they can climb their way out of what's going on with them with this diagnosis. So you want to promote and increase safety because they're at a safety risk with regards to this. I had one individual who's literally just had a pathway to the bed, pathway to the kitchen, and just a pathway to the main living space. And, we called the fire services, and, because it's a safety issue and hazard, just to maybe help them understand that, okay, she needs like a light bulb to come on and understand that this is a safety issue. Well, the fire department came in and said, well, it's really not a safety issue because she can exit out of her home. There's a clear pathway where she can exit. So it's, so you just have to figure out and kind of play with it. It's all about trial and error too with persons who have this disorder and what you see in the home. So you want to encourage and understand what will motivate change on their end. So motivational interview, I just wanted to include this as well. So motivational interviewing areas useful for assessing and it's useful for assessing and building motivation to change. So it changes the client's perspectives of importance of addressing the problem and the client's confidence and ability to change what's going on. So some strategies. You want to ask those evocative questions. So these are typically open-ended questions about your client's perception and concerns. Don't ask if they have concerns. Are you worried about drinking? So you want a more elicit conversations where it's more or less, what caused this? What triggered this? Do you understand that, this is a safety issue for you? This is a health concern for you as well. And just try to open up and see what could be the cause of this problem. I shared with you, I helped an individual who I found out later was just clutter. But you going into the home, that pile that you saw on the rating scale was a 9. She kept buying new clothes because she never washed the clothes. She would just take them off and it would pile all the way up until the ceiling. And she would just keep buying more. And yet it was like throwing out of the closet, throw up out of the closet with all these clothes, just a hallway just to the bedroom where her husband stayed because he had the disease. And she laid on the couch because he was a wanderer. And so she had the bells on the door. So if he were ever to escape, so she slept there for 7 years as a caregiver. Just to make sure the husband wouldn't leave the house. But, as I helped her throughout the process, she started to share. At first, we ended up just putting things in containers. She wouldn't discard anything. It was just, I would organize, well, these are containers for kitchenware, this is for clothes, this is for bedroom, bathroom. And that was the first initial process. So after we started to talk a little bit more, I started to ask questions. Oh, well, this is nice. where did this come from? Oh, that was from my dad. I didn't have a good relationship with my dad. But I have to, honor him, so I can't get rid of it. So there are things that are kind of deep down within these individuals that are causing and triggering these behaviors. But if you talk to them and understand, you can then help them realize too that, well, you don't need these items, this many anyway. So after a year of helping her, we were able to go back and go through those containers, and she was able to discard a lot of the items and move forward, and her house was decluttered. So it just depends too, in having those conversations. So harm reduction. This is also presented in the Hoarding project. This is part of their strategy with regards to helping individuals. So you want to set practical strategies that reduce the negative consequences of a particular health issue. You know, not to eliminate behavior itself, but to minimize negative unwanted consequences. Sorry, this is where it goes. So the goal is not to eliminate the behavior itself. Again, there's a reason why they are exhibiting this type of behavior, and that's their form of communication. So if you alleviate that, you have no idea what they're trying to tell you or show you. So it does not require the individual to have insight into reasons for hoarding. So only recognize the potential for harm to them, others, or neighbors, and agree to minimize the risk. And it doesn't prevent new items from coming in or increasing discarding. And helpful for individuals with cognitive impairments or for people who are unwilling to seek treatment. So safety, health, and comfort. With safety, you want to remove flammable materials away from heating sources, clearing wide walkways of trip hazards. So these are things that you can either share with the person who's living with them, who's caring for them, or maybe have a suggestion sheet for themselves in the sense of what are some things that you can reduce the harm to themselves or others coming in. Clearing enough room around the doors and windows. With regards to their health, clearing access to bathroom and washing facilities so they have access to that. You know, giving them some strategies and tips, or even, you know, if they feel comfortable, you helping them, you know, assist them with that task. You know, with every visit that you go in, you can just remove something, but, you know, it all depends if they put it right back to where it was too. But you want them to be safe. Addressing appropriate trash and waste disposal, and eliminating pest infestations. When it comes to comfort, addressing heating and cooling problems, designating and clearing appropriate places to sleep and eat, and then making space to conduct their daily tasks or daily activities of living. So when in building a harm reduction team, the Hoarding project suggests supportive family and friends, therapists, elder protective services, housing authority, hazardous waste team, perhaps a professional organizer for them to join a support group. There is such a thing as a wraparound facilitator, but you can learn more about that if you're interested in contacting the Hoarding project. And then city code enforcement. With regards to treatments, outside of the treatment of just addressing what's going on and having that conversation with the individual, there's also psychotherapy with cognitive behavioral therapy. So CBT is the most evidence-based practice. It is commonly implemented therapeutic intervention for compulsive hoarding. As part of CBT, the therapist may help the patient to discover why he or she is compelled to hoard, learn to organize possessions in order to decide what to discard. Before I continue on here in Reno, has anybody, it was a show way back when, Clean House. Did you guys remember that on HGTV? They kind of went through with that. They kind of showed, like, they put out containers of which things they were going to save and which things they were going to discard and which things they were going to put in a garage sale. That is kind of the strategy I used when I was helping this client of mine. So we had like a huge 20 by 30 foot container that was filled of things that we were having a garage sale for, because for her, she didn't want to donate it. She wanted to sell it first. And then she was trying to, whatever didn't sell, she was going to try to put back in the home. But then she wouldn't even sell it. It was just like so much stuff and a waste of time, because then we put it all out and people would go in and they would come up to me and I'd be like, oh, it's $2. And they would buy it. And the next thing I know, it's right back on the table. Like, how did that happen? This is not what we're supposed to do. This is not helping the behavior. So just being mindful of that. So to develop decision-making skills, Declutter the home during in-home visits by a therapist or professional organizer. So this is what CBT does. And gain and perform relaxation skills and so on to help the individual cope and eliminate the behavior of hoarding. So this modality of treatment usually involves exposure and response prevention to situations that cause anxiety and cognitive restructuring of beliefs related to hoarding. So that's a good source for them in seeking help. There are medications that reduce hoarding behavior. So it may reduce the symptoms. So it could be used to treat conditions that make hoarding worse, such as depression or anxiety. So those are the medications that they could be on to help them. So these are the resources that are available, and this was taken from the Hoarding Project. So the nonprofit organization, the Hoarding Project, there's that International OCD Foundation. As I mentioned, they were the ones with the pictures. They came up and developed that collateral material in the sense of how would you rate each room. The Institute of Challenging Disorganization, and there's also a nonprofit agency called Children of Hoarders. Because oftentimes those who are children of hoarders are the ones who are most effective mentally as well. So there are support groups, and I believe these support groups too are accessible online. So there's like an online community that you can link to or encourage them. That's harder with older adults too, because they're not as techie savvy. I know that in some of the rural areas that I presented in, a lot of the individuals came for the second half of the talk because they said, the two ladies that I had mentioned earlier, they said that the majority of their friends were hoarders as well. And there was she said there's 6 to 8 women that they were close with, but they came to the talk to educate themselves. So what they said was, I think we're going to start our own support group. And all 6 to 8 of us are just going to, discuss what you shared with us and see what we could do to then, so we don't feel, alone, that there are others out there. But it's just very interesting to see. It might be, I might research this a little bit more. Hoarding, I feel, is more prevalent in rural areas because they don't have the resources or, however they cope with loss and things like that. But it was very significant when I went out to rural areas, how many people and how many individuals shared that they were showing signs of hoarding behavior. So I also included in your handout some reading resources that were also taken from the Hoarding Project website as well. So if you were interested to learn more and to help yourselves,